So I have nothing relevant as far as financial disclosures. I am a clinician more than a lab person, so keep that in mind. If you ask me complicated questions, the deer in the headlights look is probably more my clinical background. And I really wanted to use this talk as an opportunity to celebrate. There's a lot of great Canadian platelet researchers out there, and you run down the list of people who've made an influence in this field of platelet function disorders, and it's an all-star team, and it's all Canada. So we're going to have a bit of a celebratory talk here today. Now you're probably wondering, how does some middle-aged hematologist know anything about influencers? Because isn't that a Gen Z or a millennial thing? And well, so disclosure, I live with 2 teenage girls, so they've given me all the important definitions of influencers, and I also looked it up in the Urban Dictionary, and I thought this was the cleanest and safest definition of what today's today's influencers are about. And this is not the influencers I'll be referring to today. This is a bit more hematological and a bit more. There's some substance behind it other than the traditional Instagram influencer that's out there. So my hope today is to highlight some of the significant impact that Canadian researchers have made on platelet function, and really focusing on 2 rare disorders where that impact has been markedly shown, in that being the Glanzmann's thrombocythemia registry on the treatment of Glanzmann's thrombocythemia. And we heard earlier today about the challenges of establishing registries, and so I wanted to go through a bit of the story of the success in this rare disorder. And then the very exciting journey of Quebec platelet disorder, how it evolved over the years and is still evolving today. And so it's a great story of research collaboration and successes in figuring out this very rare but important disorder that a lot of us Canadian clinicians actually have patients with this, and really over the years, and even in my career, which is still fairly new, of learning about this disorder and how we best treat it. So personally, I think platelets are fascinating. These tiny little cells that do such amazing things, where they can change shape when they're activated, as you can see on the far side of the screen. And there's a lot going on here. They play roles in really not just hemostasis, where they're the main former of the plug to deal with the site of endothelial injury, as well as the surface to be able to activate clotting factors and allow the cascade to happen. But also, there's roles that time doesn't permit to get into. Roles in inflammation and infection, roles in maintenance of vascular integrity. They do so much for such a tiny little cell. As mentioned, they're the site of the clotting cascade for activation of clotting proteins and adequate thrombin generation. And really, they're quite complex little cells. And, there's really, you think about, there's so much that can go wrong when just one small components are missing. And this is just a small list of the platelet function disorders that are out there, and probably there are many yet undiscovered function disorders that aren't even have anything to do with hemostasis. And this is really just the short list of the hemostatic platelet function disorders that we know about. And given that they're so complex, trying to assess people if they have a platelet function disorder can be complex, like this flowchart here. Painstakingly put together by Sarah Israels and Margaret Rand, 2 platelet people, well known in Canada. And really, even if we just narrow it down to those that have normal platelet counts but have functional disorders, you can see there's a very long process to go through with tests that help us try and find the reason for platelet dysfunction, but still, long way to go in making them better. They're not perfect tests by any means. And even if we go down to the very bottom, where we look at, sorry, I don't have an arrow pointing here, but at the very bottom to my right, mutational analysis, we just all do genetic studies. Well, as you'll see when we talk about Quebec platelet disorder, identifying the gene defect is really just one step, and there's a lot more that comes after that. So let's get into Glanzmann thrombocythemia to start with. So the red arrow at the very top, where you're missing basically the 2B3A complex seen here in this cartoon. And this really affects platelet aggregation. I think Glanzmann thrombocythemia is probably one of my favorite terms because asthenia, if you translate from the Latin, is another word for apathy. So I always picture these platelets as just kind of hanging out in their parents' basement playing video games, even though they're 37 and really need to get a job and just do their work. And that's really it. You have a bunch of, unfortunately, lazy platelets that aren't aggregating like they should. It's a recessive disorder and really a real challenge from a bleeding perspective. Severe mucocutaneous bleeding starting early on in infancy. These children are a real handful trying to stop nosebleeds. These are, I've had kids with the disorder where, they bleed their hemoglobin down into the 40 and 50 range and need not just platelet transfusions, but rescue with, some of the techniques that Dr. Yeaser was talking about a few talks ago. And so it can be a real problem. And for the longest time, really the treatment was to transfuse platelets, which is great for hemostasis, but eventually, because they need so many platelet transfusions, they pretty much all develop antiplatelet antibodies, and now we have no treatment. And just in the panel at the bottom, this is a sort of an aggregation pattern of what Glanzmann's looks like. Missing the 2B3A means you can't activate your platelets with the usual agonists, epinephrine, ADP, collagen, and arachidonic acid. But because they still have the 1B alpha complex, they still activate with ristocetin in the presence of von Willebrand factor. And so they do have a bit of function, but that's obviously not enough when you look at the clinical challenges that we face with this. So in the sort of late 90s, early 2000s, recombinant factor 7A started to show promise as a possibly effective alternative to platelet transfusion in these patients. And that was really led by Manchu Poon and other investigators and clinicians in Alberta, and was corroborated with colleagues in the UK and in France as well. And in these initial case reports, the usual part of the conclusion is, well, we need a good, strong international registry to really hash out how effective is 7A in these patients and how, does it really work, or was this just, something we saw in a few patients, and can we do that? And I mean, it's a big challenge to put together an international registry. Thankfully, with Glanzmann's, it's a rare disorder, so it's not a overly burdensome thing to put a few patients on from each center, but certainly there's still a lot of logistical challenges that can occur when establishing an international registry. But led by Dr. Poon and collaborators, again, in the EU and in the UK, they were able to really do so and figure out that, yes, factor 7A is an effective treatment, and I'll show that upcoming. So how does factor 7A work in platelet dysfunction? We don't really know the full mechanism as of yet, so I mean, there's still some unanswered questions in that realm, but if you think about it, you're giving factor 7A in super therapeutic doses or higher levels than you would produce endogenously. And it's probably driving both the von Willebrand factor, factor 8 part of thrombin generation, as well as just overwhelming the platelet surface that is working probably through the remaining receptors and allowing enough thrombin generation because you're just giving a lot of 7A. So that's the explanation of the day. That's probably not the full story. There's probably a lot more to it than that, and still needs to be still questions that need to be answered. And there has been similar effects shown in some of the other platelet function disorders using 7A because sometimes platelets aren't as readily available or they're not enough, or they have antibodies. So this is one of the registry successes, and you can see by 2015 we had, there was good accumulation of experience to show that treatment modalities such as 7A versus platelets, with or without antifibrinolytics, was effective both in surgical and non-surgical situations. And I mean, just looking at this flowchart, we went from a few case reports to, over 250 surgical situations where they were able to assess treatment response, and over 800 bleeding episodes, non-surgical bleeding episodes, showing, really to summarize these two papers, that there was effectiveness using 7A, sometimes either alone or in combination with platelet transfusion, that you could achieve, good or adequate response, 80% or higher in each episode. And there were very few episodes where there was non-response. And in those who maybe didn't have an initial adequate response, subsequent dosing of 7A with or without platelets did show effectiveness. And so really, a very great success in figuring out alternative treatments to platelet transfusion in this group of patients. And really, Dr. Poon, who is retiring at the end of this month, and has really been a pioneer in Canadian hematology, especially hemostasis, for a very long time in Canada. And really, this is just one of his many successes, and is worth noting and celebrating. Okay, so Quebec platelet disorder, which is a very fascinating disorder, very rare. I've had a couple patients when I was in Alberta, and then I've inherited a family here now that I've taken over in BC. And, a very interesting disorder that really, started with serendipity, as most of these discoveries do. Reading some of the publications by Catherine Hayward and George Rivard, who really were the main drivers of figuring out this disorder. It was initially reported and called Factor V Quebec, first identified in a large family from the Sorel region of Quebec, inherited in an autosomal dominant pattern with it was a unique bleeding disorder. The main characterization being major bleeding that was delayed after an injury or surgery. And initial observations showed that seemed to be platelet factor Vs, the factor V contained in platelets, that seemed to be defective, but not plasma factor V. And so understanding how the protein works both in the platelet and outside was sort of the main start, and then associated proteins that help modulate that really started this sort of very long collaboration between the centers in Hamilton and Montreal and Kingston to a certain degree, to be able to try and hash out what this disorder was all about. And so first reports were in 1984, and you can see that over the next 20 years, really, it was understanding and evolving this further. So understanding that platelets contain factor V, it's complex to this protein called multimirin-1, which is where Catherine Hayward actually came into the story. She was studying this protein, and through hearing about platelet factor V at a conference, probably not dissimilar to what we're doing today, started collaborating with the team in Kingston, who said, well, you should speak to George Rivard, who has this family that's really interesting and probably fits the story. And so everything came together, and really it kind of feels weird summarizing 20 years of research in about 2 minutes, but there you go. Really, it led to understanding that there was selective degradation of plasma proteins that were made in megakaryocytes and platelets, ended up being stored in the alpha granules, and there seemed to be degradation of all these components inside the platelet, but it didn't affect any of the plasma, fibrinogen, or other factors. And eventually it was identified, and again, here's another prominent Canadian platelet researcher, Walter Carr, who did this as his postdoctoral work, understanding that it's urokinase plasminogen activator, which seemed to be the driver that was causing this breakdown of these components in the platelet. And so really, over time, the name was changed to Quebec platelet disorder because it was identified as being primarily a platelet problem rather than a factor protein issue. And so there was further clinical description that was published in 2004, really highlighting some of the major things, including that, there was a strong family history following a dominant pattern, high chance of that. Bleeding for days after, prolonged, delayed bleeding after major cuts. Significant bleeding around procedures and surgery that, again, had that delayed pattern, didn't happen right after surgery like you would expect in a platelet disorder, but happened hours to days after and would continue. And then problems with wound healing, which again speaks to the fact that platelets play more than a role in just hemostasis. There's the vascular integrity, there's the infection inflammation piece that is really coming out in this disorder. And this is really the pattern, and these patients are all over Canada. There's been patients now identified in the US and abroad. Largest concentration still in Canada, but certainly this helped to understand this disorder better and allowed for consideration of this disorder and then subsequent testing, which has evolved over time. So the next big breakthrough was published in 2010 and was the identification that now that we knew that it was urokinase plasminogen activator, it was figuring out is there an actual gene defect that caused this? And so there was a lot of work and they couldn't find any particular mutation. Eventually it was found that it's not a mutation specifically, but it's a duplication of the PLAU gene, which produces urokinase plasminogen activator. And that seems to be the gene disorder that causes Quebec platelet syndrome. And so, great, we have a gene, we can test for it now, we know how to test for it. Story's over, right? No. Lots of questions. Well, why does this duplication cause this increased degradation of hemostatic components in a platelet and causes platelet dysfunction? That was sort of the next big hurdle to come over. And so where we were at that time was we had this dominant disorder. It was a gain-of-function defect in fibrinolysis that only happened in platelets and not plasma. You had this PLAU duplication, which caused UPA overexpression up to 100-fold increase in platelets or maybe more in megakaryocytes. And it was this plasmin-mediated degradation of the alpha-granule proteins and accelerated fibrinolysis, which is why we see delayed bleeding, why we see poor wound healing in these patients. And so this was the next question, is how does PLAU duplication cause this overexpression? And so that was published in 2020, and again, Catherine Hayward's group showing this phenomenon of what we call enhancer hijacking, which was first reported in various forms of Burkitt's lymphoma, where you have this sort of self-perpetuating growth that you see in aggressive lymphoma. And what happens, so if you look at someone with normal PLAU, no duplication at the top, you have the PLAU gene, and then you have the enhancer, and you have a boundary that stops further transcription of the protein. And so what happens is you get normally functioning platelets. But what was found further in diving into this a bit deeper was you had this PLAU duplication, but you also had duplication of the enhancer beyond the normal boundary. And so this was found to be the reason where you had this continual overproduction of UPA because you had no way to stop the production as you would in an unaffected person without this duplication. And so you end up with this pro-fibrinolytic group of platelets, which really doesn't solve any of your problems when you're trying to stop bleeding. So that was, there you go, almost 40 years of a journey to, I guess, 35 years from 1984, 36, 38. I don't know, my math is on the fly, isn't working today, but a long time. And really, a continually evolving story. I mean, we now, from us as a clinician, it's great that we now have an easy way to identify these patients. We look for the gene duplication. We can start to explain why this happens and why some of our treatments work in these patients. And really it's been a benefit to our patients who know that they can test their children before problems are found, or they can consider how they want, how many children do they want, if that's a concern to them, and really allows us to really help these patients throughout their lifespan, choosing the right therapies and being able to monitor them appropriately. And all thanks to a lot of this research, which, yes, I can summarize in 20 minutes, but it's decades of hard work. And it's all Canadian, so we have to celebrate that. I should have worn my Canada shirt like the other Mark, so maybe next time. But yeah, so really, those are just two stories that really highlights the large amount of platelet research that's occurring in Canada, and something we should all be proud of. And it's resulted in major advances in the understanding and treatment of platelet function disorders, and it's has worldwide benefit, both to those of us who look after these patients and to the patients themselves. And that's my talk. Thank you for listening, and I'll take questions.
Hi, Mark. That was fabulous. So I just want to start off by saying your point about not knowing how factor 7A works. Actually, it's sort of like Bitcoin. Nobody understands how it works. I'm just curious, the Quebec 5 with the hyperfibrinolysis that is megakaryocyte specific, I suppose. Are there any other manifestations of the disease other than bleeding? Do they have increased risks of tumor or metastasis, for example? Anybody know? And maybe it's just too rare to know that.
Yeah, not that's been reported in the kindred. I mean, thankfully, these are large families that have been studied, and there hasn't been any report of higher risk of malignancies of any kind. Outside of the hemostasis and the poor wound healing, that seems to be the major manifestations. And I mean, they've looked as a lot of these patients have aged, whether they're at increased risk of cardiovascular issues or more on the clotting side, and that doesn't seem to be the case either. I will say that the one family I had in Alberta was interesting because, normally I go in and I see these patients. So I go in and I say, well, what brings you in to see me today? And the dad, who's this very gruff, rural truck driver from northern Alberta, he's like, well, I have Quebec platelet disorder and I want to know if my son has it. I was like, oh, okay, well, we can figure that out, Not something I was expecting from this, guy from the boonies, literally, telling me about his Quebec platelet disorder and how his mother had it and how she used to be in this part of Quebec. And it all made sense. And the kid actually did have the same disorder as his dad. But it was just a fascinating way to start a consult on a morning clinic. I've shocked them all. Only one question. All right.
They'll be all over you at the coffee break.
Yes, that's fine.